I'm Nienke Wijdkamp. I'm currently working in the University Hospital of Zurich in Switzerland, and I would like to tell you today something about the head and neck treatment with an SGRT device. So I think it's good to start with our current situation. We have 3 Linacs, which 2 of them have an SGRT device from SGRT. Our X machine on the upper picture has the SGRT device since July 2014. And the picture below is a TrueBeam machine and has the device since May 2018. But beforehand, this device was installed on our Trilogy machine. How did we thought about the idea of treating patients in head and neck treatment with an SGRT device? We had this very unique case. We had this special patient who came 3 times to the CT scanner for having a mask for treatment, but still she couldn't do it. She was too claustrophobic. An operation for her was not an option, and we started to think, what can we do? Because in the end, she needs treatment. And then we discussed with our doctors, our physics, and we said, well, we can try. We can see if this is a good option for us. I think it has to be said that this patient could have lain still for a long time. So we gave her some immobilization, so her head and shoulders, we knew where we had to position her, and we made sure that we had an MRI from over the chin and the neck and on the shoulders. This is what it looked like during treatment. Another thing is that she had a really small volume, so it was only a T1, T2 larynx volume without any lymph nodes involved. As soon as we were happy about our setup, if the values were close as possible to 0, we would leave the room and we would image. And what we saw actually during this treatment for her, that the beam was held when the thresholds were reached from 3 millimeters, and I think it's a good thing to know that we give our patients a swallowing commando. So we ask our patients if we start the beam or if we make an image, please do not swallow anymore. And we did that for this lady as well. But what we saw is that actually she swallowed. We saw it with the SGRT, and the beam was held during that moment of time. The patient was, of course, very happy and compliant that we could do the treatment and that she was able to have the treatment without a mask and no surgery. So why would we not have a more open mask approach? I think it's clear that it would be very happy for the patients, more patient comfort. We would assume that it has a comparable setup compared to the closed masks. We can monitor the neck area for swallowing or any other motion. And it would be maybe an interesting fact to see if we can monitor weight loss during treatment. So first, these are our masks at the moment. You see it's quite closed, it's only open around the nose and the mouth so the patient can breathe normally. And then also we saw some of these masks. These are masks currently in treatment, and you see that it's already quite open and free. And that's due to patients who can't bear the mask anymore, who have pain, who get a swollen face because of medication, or they lose weight and we have a bolus and we want to have it on the skin without any air gap. So we had to cut the mask out so the bolus would be on the skin. So we thought, well, let's see what we can do. This is what we made of it. Because before we are introducing a whole new system, we wanted to make sure that that the system is doing what we are thinking, and we made our own open face masks. As you can see, it's for the face it's open till over the eyebrows, under the nose, and as far as possible to the ears. This is actually what SGRT says is a good idea. And we also cut out the neck area. So the workflow, what we did before treatment, the patient screening. Only patients are included with a T2, T1 larynx treatment without any lymph nodes involved. And when we generate the CT scan, the mask is already made. In our clinic, we make the mask on the CT scanner. So we make the mask, wait till it's hard, cut out the neck area, and then make the CT scan. And then, of course, import all our data to the Aligner T system. and preferably any treatment without any bolus. So then the patient comes to the machine, and we make sure that we have 2 MRIs, one in the face region and one in the neck region. And we start with the face region. So the patient is under the mask. We drove into the ISO center, and we put the Aligner T system on, and we correct on the face MRI for the rotation roll and pitch within 2 degrees of rotation. Then we switch to our larynx MRI, and we adjust also the translational corrections. And if we're very happy about it, we will leave the room, we image, and apply the shift, and if necessary, make a new capture. During the treatment, the gating beam was on, so the beam would stop as soon as there was any movement on the larynx MRI, because that's the region where we're treating. I think it's good to know that we still said to the patient, please do not swallow. So we had 7 patients in the open face mask and 7 patients in the closed face mask. Every patient was evaluated for post-match shifts, and the patient with an open face mask, we also evaluated the intrafractional motion. All patients were treated with 2 arcs and 6 MV, and we had 20 to 34 fractions per patient. I think it's a good thing to remind that we approached for a comparable setup to closed and open masks. And this is the shifts after the cone beam was applied. The blue ones are the closed masks, and the green ones are the open face masks. As you can see, there's a slightly difference, but we did a test. There's no significant difference, so the setup is comparable. Here you can see the difference between translation and rotations. The translations is maybe clear that it's easier to set it up. I feel that using the system more and more in these cases, it gets easier to correct for roll, pitch, and rotation in the mask, but that's something you have to learn. It's different from what you're used to. Here, quite quickly, all the patients set out, and just to make clear that there's no big difference between patients. It's not that one patient is really good, the other patient is not good. And as said before, the rotation roll and pitch is a little bit more outside it, more spread compared to the translation shifts. Then we come to our monitoring data from Aligner T. This is a setup and cone beam CT monitoring data for a patient, and I'll quickly explain what we see here. The first red part, the first part, you can see the mask is on the patient. We just put on the system, and there's still some difference. So we adjust that till we're happy. We leave the room, make the cone beam CT, and as you can see, there are some outliners on the longitudinal, and that's the swallowing motion. So we say to a patient, please do not swallow anymore. Most of the time they swallow, so we wait a quick moment, then start our cone beam CT, and then we tell them, well, we did our image, you can swallow again. And they swallow a few times, and then in that time, we are looking at our image, and we shift. This is what we found. The mean absolute shift during beam delivery are quite small. That's very good. That means that the patient lies still. But we also see that if the beam is whole, the mean shift is quite big. We see in a longitudinal direction, which we expect a shift of 4 millimeters with extra outliners as the lowest table with maximum shifts of 19 millimeters in longitudinal direction. This is quite a big shift with such a small volume. Here you can also see it again, it's the same data, that there are shifts very big, up to 4 centimeters almost. So what do we see? We see that the use of an open mask gives a very comparable setup to a closed mask. We are able to gate our beam to prevent our motion during treatment, and we assuming that we increase the patient comfort. To make sure if that's really true, we're going to start a phase 2 randomized trial hopefully beginning of January, where we can make sure that actually the patient comfort is increased. What can we do next? I think it's a good thing to say that the staff needs to be trained. Like, you have to make clear, okay, if I see pitch in the patient, does that mean that the patient has to move in the mask up or down? Is it just the chin that moves and that's it? This is something you learn by doing. We still image, so we can see it, but it's very helpful to do a session or something. Maybe there are any chances we can do in the future a PDV reduction, because we see how much the patient is moving, and it would be nice if we get a bigger amount of patients in these studies. So it would be nice if we could include patients with lymph nodes in the treatment area, and for extra patient comfort, treating patients without any swallowing commands anymore, so they can freely swallow, breathe, and we can see what happens, so the beam will stop. I would like to thank my team back in Switzerland, and if there are any questions.